Hello, my name is Dr. Alison Graham and I am Spinal Cord Injury Consultant at National Spinal Injury Centre at Stoke Mandeville Hospital in the United Kingdom. So thank you for asking me to participate. Really what I'm going to talk about is a very personal based view of what we have been doing in measurements in spinal cord injury or what we haven't been doing. So the first take-home message I would say to you is don't do what we did. In the 20 years of our unit as paediatric service, we plunged right into the clinical side of the service and we didn't really set up the correct database. The introduction of a data manager took over 10 years and we're still actually working on what we need to know. I think the glaring issue that we found within the United Kingdom is that we all provide different models of care in order to take the child from onset through childhood and into adolescence and then into the adult services. We all think that we know what works well, but so do all the other providers that are providing very different models. So exactly what is the best care and how do we provide that and how do we measure what we're actually doing? What we have to measure is a whole variety of different things. We must record information that's required by NHS England, and so how do we compare with other commissioned units, which in itself is quite difficult because there only are pre-COVID 12 commissioned beds for spinal cord injury for 66 million of a population, and currently we only have 9 post-COVID. The information required by the service itself for evaluation sometimes feels much more important to us. How the child progressing, obviously incredibly valuable, and the patient-reported outcome measures, which we feel is the kind of value base of healthcare that we do. And then what do we do about international data? How do we talk in a common language and how do we use those data sets? We have to provide a sort of dashboard display of measurements in order to get paid. So they want things like the length of stay in hospital, the delay it takes from the paediatrics to us as a specialist centre. They want to know about the SCIM uplift because that's the measurement that they have chosen, and also how well we document INSCE for those aged 6 and above, although we take children right down from onset from birth. They also always want to know about bed occupancy and how we can fill ourselves up even fuller. It's useful that bed occupancy does relate to payment for service, but otherwise it's too general a measure and really just irritates the clinicians. The information is entered into the National Spinal Injury Database for England. At the moment, it's not actually linked to either TARN or UK ROC that I'll talk about. And we would like much more of a rehabilitation efficiency index rather than just broad brush strokes. So TARN is the Trauma Audit and Research Network, which reviews all trauma care across England and Wales from the point of onset. Scotland has one similar called STAG. Initially it was for adults, but it now has increased input on children's major trauma outcomes, and it really has been incredibly useful for improving the care of the traumatic patient in the United Kingdom, and the website is there. For the non-traumatic onset, then UK ROC was started up as the United Kingdom Rehabilitation Outcome Collaborative. However, very adult orientated, inpatient mainly, and collaboration was there from British Society of Rehab Medicine and the Australian Rehabilitation Outcome Centre when it was first set up. So what would the Rehabilitation Efficiency Index that we've been pushing for? The length of stay isn't a clinical measurement. We want to review the impact of our intervention and why the time may be longer, but why it may be much more important to do that for the individual child. What measurement that we use as part of this, divided by time, we could use the SCIM3 or the Children's Needs Assessment Checklist. We would prefer to use the Children's Needs Assessment Checklist as it picks up much more global change, and we don't find that SCIM is sensitive enough. However, not enough people are using the Children's Needs Assessment Checklist for us to compare what we do. So that's one of the problems that we're finding. So what do we measure within our service? It covers what the individual disciplines do individually and collectively, and it inputs into the patient's progress. A major part of the work that we do throughout the sort of involvement with the children and their families is on the children's discharge report. It can often end up about being 15 pages per year, with all the progresses and updated outcomes, and we have masses of information. The problem is if each part of that data sits in an individual report, not on a database. We have a massive need for spinal research fellow or person or a data manager to create a database that we're able to interrogate and actually dice and slice. The initial work that we did do was very much based on Ebba Bergstrom's work. He was a research physio, but that was very much concentrating on the skeletal management throughout childhood, but it at least was a basis for us to start working on. I've talked about Children's Needs Assessment Checklist. It really covers all the domains that we sort of input into as professionals when we're looking with the children throughout childhood. With the physical care aspects that are up there, separate questions for children who are ventilator dependent, activities of daily living, skin, bladder and bowel, a lot about knowledge of the spine and promoting healthy growth, mobility in wheelchair and equipment, community and education, discharge coordination, psychosocial health, which includes not just mental health but participation and integration into the child's community. So the Children's Needs Assessment Checklist is a practical tool that we use for planning the rehabilitation but also assessing rehabilitation outcomes. A lot of the work has been published. The first one probably was through the Go Planning programme, and it was published in the Journal of Spinal Cord Injury Medicine. It was 2007, and it's in the supplement. Webster and Paul Kennedy being the authors. The Children's Needs Assessment Checklist is a patient-reported outcome, but we've been pushing more to get involvement that looks at what other aspects that can we sort of gather information about our service. We do want it to be from the child if possible, but also from the parent. So what we've looked at is the measured process of care, which is from one of the tool sets from the CAN Child Group in Canada. We use the MPOC 20, which is a self-report measure of the parent's perception of the extent to which health services that they and their children receive are family-centred. It's licensed and it can be available from their website. We also have started looking at the Give Youth a Voice measurement. It's a 56-item thing, but it's a measure of the youth's perception of the client-centredness of the service for those who want to participate by themselves and not have a mum or dad answering for them. The other thing that we like about this is it actually allows a separate validation of what staff feel, and we use the MPOC SP, which is service provider, and we ask the staff for them to contribute to what they feel, what it's like for them taking part in the rehabilitation process. So from this together, we can find out our strong points and our weak points of the service. It gives us reassurance of what we're doing well. The details of our report that we produce was one of the things that people did like. Families said that we do include them as the expert in their child's care. And the other thing about finding out about what you don't know about yourself, good and bad, is really important. It allows you to sort of plan your sort of improvements for the next year. We were good at being very welcoming and calming to the family in a very difficult position, but one of the problems was it would take far too long to get the reports out, and we do know that. So, in order to go forwards, we have to go backwards. We are incredibly information rich, but data poor. Our plans are to retrospectively populate a working database linked to what our clinicians do and also what our research department can work hand in hand with us to improve the service and to sort of be a bit more sort of international players. We have done some work with Europe, and based on asking people what it is they need and what they want sort of developing, and that's been through the PEPSCate initiative, which hopefully will get to publication quite soon. We're also looking to review the external links to the national databases, who are currently all in a state of flux at the present time. I think unless we all feel that our information is going to be reviewed well, it's much more difficult for us to really want to participate in producing data. It doesn't just get sort of lost in the ether or sort of be used not for the benefit of clinical purposes. And personally, as a unit, we are very happy to collaborate despite our current isolationist COVID and Brexit status. So thank you very much for listening to my Tuppence Worth. Thank you.